presentation is by Vishal RAVAL from LV Prasad Institute.
Okay, so good morning. So I'll be presenting an interesting case of optic. I'm not sure my slides are not visible. Can somebody? Yeah, okay. So good morning, one and all. I'll be presenting an interesting case of an optic disc tumor, especially which was very unusual location for me to kind of and had a kind of diagnostic dilemma how to deal with such kind of tumors. So I have no financial disclosure. So directly going on to the patient, this was 71-year-old male, complained of diminution of vision in the right eye, which was sudden, just 1 month back, and past history of a chronic smoker for 25 years, no other associated significant past history. Left eye visual acuity was NPL, and rest of the anterior segment in the right eye was absolutely okay. Left eye had RAPD with normal intraocular pressures. If you go the fundus photography, this is what kind of patient presented to the clinic. You could see a large kind of amelanotic lesion, 4 to 5 disc diameter in size, which had a kind of very irregular margins with surrounding cuff of subretinal fluid with few specks of intraretinal hemorrhages. On the surface of the lesion, there was no kind of pigmentation, but you could see there was intrinsic vascularity, which is
I'm going to ask the audience to tell the diagnosis.
okay. Yeah, so I think this was what the patient presented to the clinic, and looking at this, particularly in a country like India, we usually come across few differential diagnoses before we jump on to oncology. So I think I will ask the audience, what do you feel when you see this kind of cases in your clinic?
I'm going to go around from here.
Yes, sure.
Please tell us your name and where you're coming from and what do you think it is. Make the best guess. Everybody's guessing, okay, so you can guess.
I'm from Japan. Okay. A very difficult, strange appearance. I didn't see such a tumor.
Guess? You want to make any guess at all?
Very, very difficult.
Okay, no problem. You, Anda? Yeah. Okay, here's the next one.
Yeah, Handa from Taiwan. So based on the age and posterior location and proximity to the disc and the color of the lesion, I would, first impression would be astrocytic hematoma.
Okay.
Yeah.
Good.
One diagnosis, one diagnosis.
One differential we have.
We'll figure it out. Okay, and how about you, sir? What do you think?
Yeah.
You're as good as anybody here.
Yes, yes. I think what he says, I also feel the same. No other clue.
Okay, no worries. I'm going to quickly. Anning Chow, also from Taiwan. Go ahead. Anning.
Yeah, I agree, but we also have to rule out like matte because of the color. So this is one of the differentials.
Metastasis.
Yes.
How about you, sir?
Yes, to me also look through metastasis. Yes.
Metastasis. Very nice. Okay, NLP vision. And madam, what do you think it is? Just make a guess if you are familiar with the term.
Metastasis.
Metastasis. How about you, sir? Not familiar with this? How about you?
Yes, Rajanavan is there.
We have the expert walking.
Mudit is also there. Okay, he knows the diagnosis.
I know. I agree with the first two as well, but I did my training in Cape Town, and there we taught to always think of TB. So maybe TB granuloma or something.
Rita, well done. What's the diagnosis? Just quickly. Nothing here. NLP vision. What do you see? Hi, Bhamna. Very nice. Hey, we got expert panel. Right?
Yes.
I'm 50. Adult, 70 years old.
Adult?
70-year-old.
70 years.
No perception of light. Let's be quick. We don't have so much time. Bhamna, go ahead.
With what?
Diagnosis.
Age?
71.
70.
NPL, no PL.
Metastasis. What do you think? Metastasis. What do you think? Okay. Everybody said metastasis. That may be wrong, but that's fine.
Okay, I'm happy. So we went
We'll
ahead.
carry on. We'll find out. I don't know.
Yes, we'll.
I would say, okay, I wouldn't say anything, but it's okay.
Okay, so we went ahead and did the imaging what we had in our facility. So again, I think one of the audience told us about retinal astrocytic hematoma, and I think hematomas are usually associated with calcification. And you can see on the ultrasonography, we couldn't see any kind of calcification. This was a solid homogeneous lesion, particularly arising kind of from the retinal structures. I think underlying choroid or even the optic nerve doesn't look kind of involved or dilated or kind of edematous. You do the OCT imaging, again this shows the location of the tumor. Again, it is kind of more in the retinal compartment than in the choroidal compartment with surrounding subretinal fluid, as well as you could see there is a posterior backshadowing suggesting that this is a solid homogeneous lesion, not a something kind of heterogeneous lesion or a kind of cystic lesion which might be kind of determining the underlying choroidal compartment. You do invasive imaging such as fluorescein and ICG angiography. You could see from the early to mid to late. You could see early hyperfluorescence, which kinds of increases in intensity as well as kind of phase, where in the late phases you could see leakage, particularly in the subretinal compartment because of the associated subretinal fluid. OCT angiography, we have a tool, so we just kind of wanted to see how it looks, because on clinical examination there was a huge intrinsic vascularity which we could see on the color fundus photography, and this was nicely depicted on the OCT angiography, the intrinsic vascular, the intratumoral vascularity of the tumor. Yes, doctor.
So this intratumoral vascular, is it choroidal or is it retinal?
Retinal.
This is retinal vascular?
Yes. So this is the slab what we have taken. This is in the deep capillary plexus.
Does that,
Sorry. Yeah. So the next investigation imaging, because we couldn't identify or see the optic nerve, we didn't know from where it is arising or whether the underlying optic nerve is involved or not. So we went ahead and did an MRI on hyperintense. It showed a kind of T1 on hyperintense and T2 hypointense lesion. Again, the longitudinal part of the optic nerve, whatever we could see on the cuts of MRI, looks absolutely okay. There was no dilatation or kind of tortuosity or enhancement on the retrobulbar part of the optic nerve. So this was a lesion which was sitting over the optic nerve, but it was not affecting the general length of the or the proximal part of the optic nerve. So then there was diagnostic dilemma. We don't know what it is. This is the amelanotic optic disc lesion. We sent to our uveitis clinic to rule out any inflammatory granulomas, but sudden loss of vision, NPL, 1 month duration, unlikely it will be inflammatory, but we do work up our all kind of granulomas for our inflammation, in particular in country like India for tuberculosis sarcoid, and all the tests came out to be negative.
why is it not melanoma?
It can be, but I have not seen amelanotic optic disc melanomas. At least I have not come across this kind of presentation for a melanoma onto the optic disc. So my differentials were mostly, as most of you pointed out, to be metastasis, and whole body PET CT scan was done. It showed some kind of lymph nodes positivity in the apical region with a small cystic lesion seen on the 6th rib. Now we went back to the medical oncologist, asked them to take a biopsy, but then they told it is in the rib lesion. It would be detrimental for the surrounding structures, especially the pleura of the lung. So considering the location of the lesion, NPLI, and we being retina specialists, it is easier for us to put a needle and take a biopsy. We went ahead and took a vitrectomic based lesion biopsy and sent for cytology. So this is a small video which demonstrates how we took the biopsy for this lesion. So we directly went ahead with a 25 gauge vitrectomy system, and to my surprise, this was not that kind of thick or kind of solid lesion. It was more like a cheesy lesion. It came out very easily with the cutter kind of aspiration as well as your minimal cutting, 100,000 cut rate per minute. And once I took the biopsy, as you can see, it was a highly vascular lesion. So there was some bleeding which was associated with that, which stopped with raising the intraocular pressure. So the cytology, again, it's shown on kind of cell block, loose clusters with single scattered and few glandular patterns. But important feature, what we could see, there was a signet ring-like cells with multinucleated giant cells within that. So I think this raised our suspicion more towards metastasis, and then we ran for both PAS stain, which showed the signet ring cells stained red, seen on the left-hand side photograph, as well as the Alcian blue, which show the blue color cells, particularly positive for the acidic mucus, which is very characteristic of mucin-related carcinomas. Pan-cytokeratin again was positive, showing diffuse and strongly expression in the cytoplasm as well as in the lesional cells. Just as Dr. Singh told about melanoma, HMB also we regularly do to rule out melanoma, and that was negative, thereby ruling out any melanocytic origin of the tumor. So cytological diagnosis gave us a provisional diagnosis of optic disc metastasis, possibly from the aerodigestive tract because of the mucin, either from the lung or from the gastric adenocarcinoma. The whole body PET CT scan, as I told, showed some lymph nodes involvement with the right 6th rib lesion, and we went ahead with the further IHC markers, especially to rule out whether it is a lung or it is a gastric adenocarcinoma. And as noted, CK20, which is a very strong expression for lung adenocarcinoma, as well as thyroid transcription factor 1, which is again very strong marker for lung adenocarcinoma, both were negative. So that pointed out towards the final diagnosis of signet ring gastric adenocarcinoma. Follow-up patient was referred to the medical oncologist for further screening of the possible primary from the aerodigestive tract, especially gastric region. A lymph node biopsy was advised. However, the patient deferred for any further investigation in view of his poor health status. So my message is, I think multimodal imaging does helps in our few of our oncologic cases, particularly if it fits into your criteria wherever you want to look for a particular tumor, whether it is arising from the retina or the choroidal compartment. Invasive imaging, especially ICG angiography, does helps particularly in cases where you want to look for the vascularity or the surrounding structures associated with the lesion, especially retinal detachment or subretinal fluid. Last but not the least, I think biopsy, I think clinches the diagnosis, especially in cases where there is a diagnosis dilemma or you are not sure about how to go about in such cases. And optic disc metastasis, as I say, it constitutes very small cases of retinal or the choroidal metastasis compartment of the disease. And as we all know, prior cancer history is present in only less than 50% of cases. So as an ophthalmologist, we might be the first person to diagnose a underlying primary elsewhere in the body. And that's why a role of multidisciplinary approach or a very good dialogue with your medical oncologist as well as your surgical oncologist will be fruitful. Thank you.
Let's look at the first photograph again, just to kind of get in some thoughts about it. Now we know what it is. I guess because it's centered on the disc, you can't tell what kind of circulation it is. Is it retinal or choroidal? I mean, I can argue that this looks like, if it goes outside the disc, it looks like choroidal circulation.
Okay. Yeah, I think one thing might be the retinal vascular surrounding are absolutely okay. There is no dilatation or engorgement of any of the vessels surrounding the lesion. So that might give a clue that it might not be arising, but the OCT, as I showed, again, yeah, this. So I think here, I think underlying, at least the surrounding choroid in the lesion in and around the adjacent choroid looks absolutely okay. There is nothing in the choroidal compartment in that particular area.
And the other thing we always say, metastases have disproportionate amount of detached retina.
Yes, exudative RD.
And we have no exudative RD.
There's no exudative RD, yes.
Which is kind of very atypical,
Atypical.
for metastasis.
Yes.
And solitary and, nothing else. So
Nothing else.
To take you to metastasis, except you say it's yellowish color, but I couldn't really tell whether it's really retinal or choroidal. I thought the circulation looked more choroidal. Like a ribbon-like pattern,
Yeah.
So this would be what we would see with intrinsic vascularity of melanoma.
Melanoma, yes, that's what I was thinking. Double circulation, what we see, both retina circulation as well as the choroidal circulation.
Excellent,
Okay.
excellent case. Thank you
Yeah,
very much.
thank
Any
you.
comments? Anybody has any comments? No? We have one other presentation, but that's Optic, right?
Yes.
Okay, and before that is mine.